My name is Mandeep Mehra. I'm the William Harvey Distinguished Chair in Cardiovascular Medicine at the Brigham and Women's Hospital, and I serve as Professor of Medicine at Harvard Medical School. The Momentum 3 study, I must take you back for a moment, was started almost a decade ago. And the original trial which we designed was a one-to-one randomized trial that compared the HeartMate 3 LVAD to the older generation HeartMate 2 LVAD, which was an axial flow, mechanical bearing possession LVAD that was associated with an increased risk of hemocompatibility related problems. So Momentum 3 was the largest LVAD trial ever performed, over 1,000 patients randomized. And, in cardiovascular medicine, 1,000 patients might look like a small study because we're used to having tens of thousands of patients for pharmacological therapy. But you have to recognize that this is a very, very small and difficult population to deal with advanced heart failure. And on top of that, taking a very, very serious surgical process like implanting an LVAD. It's 1,000 patients represents almost the equivalent of what you would enroll in a pharmacological study of tens of thousands of patients. So I want to place that in context. So anyway, this original trial was really designed to go out to only 2 years. In those days, in the early days, we used to think that, these patients are so sick, they're likely to die within months to a year. Well, even 2 years worth of survival with an LVAD is a significant survival. So the original trial was designed for 2 years. And the trial at the end of 2 years clearly suggested the superiority of the HeartMate 3 over the HeartMate 2. And this then became the most approved and most prevalently used device, the HeartMate 3 in the world. When we went to the United States FDA for approval, they immediately approved it based on the benefits of the Momentum 3 trial. But they told us, look, we want you to follow these patients up for 5 years. And we said, oops, we've already concluded the study at 2 years. We always thought that was about what we could get in life gain for these patients who are so sick. And they said, well, look, your results are so good, you should really think about what happens at 5. Well, we went back to the drawing board and we redeveloped an extended phase protocol. We arduously went back to every center and every patient and tried to get them back to consent to the new protocol. And this protocol basically followed out the randomized patients to 5 years. So that was the purpose of this extended phase trial, which was done as a separate trial from the original Momentum 3 trial as an extended state trial. We followed these patients out to 5 years, and I must say that it was very difficult because while we were following these patients, we encountered this thing that we're all dealing with called COVID-19. And so not only was it difficult to get consent for patients, but imagine bringing these very sick patients in with implanted pumps to the clinic for 6-minute walk tests and functional assessments and research protocols. It's not very easy. So we had a really, really tough time, but we were very successful in accomplishing the trial. I must say that when we finished the trial and we saw what we had, given the challenges of COVID-19, the steering committee immediately concluded that the principal endpoint of the trial ought to be survival out to 5 years, not just hemocompatibility-related adverse events, which we had already shown to be superior with the HeartMate 3 at the 2-year mark. Why was that important? Let me point out to you that at 2 years, even though we showed that there was a clear superiority of the HeartMate 3 pump in the original trial, we were unable to show a clear survival benefit at 2 years compared to the older pump. So people said, well, it's great that you have less strokes. It's great that you have less bleeding. It's great that you need reoperations that are less. So it improves the journey of the patient and the cost effectiveness. But you don't really impact survival, do you? And that was really why we also agreed with the US FDA to say that if if these benefits are extended at 5 years, we should see a survival benefit. And therefore, the primary endpoint of this particular extended phase was to really scratch the surface and find out, is there a survival benefit to the device? The primary endpoint of this study was survival free of a disabling stroke or the need to reoperate for pump malfunction. So typically, what would happen is that even though there's a risk of stroke with these devices, the most terrifying thing is to have a disabling stroke, a modified Rankin scale stroke greater than 3, one that basically leaves you relatively debilitated after about 2 months of the original stroke event. That's essentially the definition. And the second point is that when the pump starts to clot up, that you have to bring them back in and then replace the pump. So you can imagine how terrible and costly that secondary endpoint is. So the primary endpoint of the trial was survival free of a debilitating stroke and the need to replace the pump for a malfunctioning pump or to remove the pump for an indication such as transplantation. What we showed at 2 years was a clear superiority on these endpoints. And in fact, we were able to show that there was near elimination of the need to replace the pump for pump thrombosis compared to the older device. So the engineering really, really works with the HeartMate 3. We were able to show that stroke rates, which had never in decades been reduced with LVAD therapy, were now halved and were only seen during the early surgical phase, indicating that if we could get smarter about preventing strokes during the implant phase itself and during the first 30 days of the operation, that we could reduce the stroke rates down to what a normal heart failure patient would experience during the lifetime journey. So strokes were really improved dramatically. And we also saw that the intrinsic pulsatility algorithm reduced bleeding episodes by about a third. But what I said we didn't show was a difference in survival at 2 years between the two pumps. So those were the main findings of the 2 year trial of Momentum. I'm very pleased to report that the 5 year findings were a bit unexpectedly in favor of the HeartMate 3. So, the first and most important finding was that we chose to modify the primary endpoint to survival due to any cause, and we found a marked improvement in survival at 5 years. Why? Well, we found that cause-specific mortality was reduced exactly in the domains where the engineering of the pump would be predicted to influence, such as hemocompatibility-related deaths. So this time, deaths due to bleeding were reduced, deaths due to reoperation were reduced, and deaths due to stroke were reduced dramatically. The other important finding with the difference in survival in favor of the HeartMate 3 was that for the first time ever, and we've never seen this for this population, the median survival improved from what we used to look at for about 2 to 3 years out to well beyond 5 years. So now these patients have a life prolongation benefit that is years and years and years and not months and months and months like we used to see before. And that's all because of the engineering with these pumps. We also looked at the primary endpoint of the trial, and while there were a number of missing values in that particular domain, largely because we could not collect all the information as a result of COVID, etc., we did not see any new adverse events that emerged in the late course of the disease journey with the HeartMate 3. And in fact, we showed that the superiority of the pump was continually preserved even at 5 years, suggesting that these pumps have now entered into a completely new era, one where we can say that the life gain that is attributable to pump implantation is it changes from what a patient would experience without a pump of, say, a median survival of 9 months to a median survival that exceeds 5 years and could go as much into 6 and 7 years. So we are really talking about a complete new definition of how we look at LVAD therapy in patients who are otherwise optionless, escaping the effects of medical therapy with heart failure, who now have this off the shelf capability of using a pump.